will be in the chat box and are on this screen. So I have the distinct pleasure of introducing our Grand Round speaker today, Dr. Linda Giudice. I think most of you know her. She is a distinguished professor in our department. It is not only the former chair of our department, but she was also the first woman chair as well, too. Yeah, exactly. I don't think we talk about that. We just kind of like, she was here. She directs the UCSF Stanford Endometriosis Center for Discovery, Innovation, and Training and Community Engagement. As a biochemist and reproductive endocrinologist, she has dedicated her career to caring for patients with inflammatory uterine and ovulatory disorders and associated comorbidities, as well as advocating on their behalf. Her groundbreaking research leverages precision medicine approaches to illuminate endometrial function in health and disease, while developing innovative diagnostic and therapeutics to improve reproductive health outcomes. Dr. Giudice has mentored over 300 students, fellows, and faculty, authored more than 400 peer-reviewed publications, and co-edited 7 textbooks spanning gynecology, endocrinology, the endometrium, endometriosis, and environmental health. Dr. Giudice's accolades are numerous. She is past president of ASRM, SRI, MIWES, IFFS as well too, and an elective member of the U.S. National Academy of Medicine, and has been recognized as a giant in obstetrics and gynecology by the American Journal of Obstetrics and Gynecology. On a personal note, you guys know I love stories. Early on in my, I don't know if you remember this at all, Linda, when you were chair, but early on in my career, I found myself at a serious crossroads. I felt like I wasn't achieving the goals I had for myself. And honestly, I was questioning whether I belonged in academic medicine. And I was thinking about leaving completely. Linda, who was the department chair at the time, reached out to me directly. And she let me talk, basically ramble for 20 minutes before responding with her signature blend of brevity and wisdom. And in her concise, matter-of-fact way, she said, "I think you're making a mistake." Period. That was it. Period. And then she reminded me of all I had accomplished thus far and gave me advice that completely shifted my perspective. She helped me see how I can align my passions for health equity with what I felt like was the immovable borders of academics. I don't know if she remembers that conversation, but I do. It was pivotal. Every time I reflect on my career, I think of her advice and the confidence she instilled in me at that critical moment. And I'm sure she's still going out and giving this great advice to all of her. I see why she's like, yes, all of her mentees. So thank you, Linda. Today, Dr. Giudice will share her insights on precision medicine and endometriosis, accelerating diagnosis and improving patient care. Please join me in welcoming her.
Well, thank you, Andrea. Yes, I do remember that conversation, and I'm not shy about saying someone made a mistake, including to myself. So today, I'm delighted to be here to talk about precision medicine and endometriosis. And the goals are to learn how precision medicine and advanced technologies can advance classifying endometriosis as a multi-system disease beyond the lesions. Discover how non-invasive diagnostic and novel therapeutic approaches could change the paradigm of care, and to be inspired to join the global and local efforts to increase awareness about this disease and to increase patient access to quality care and improve quality of life. Can you hear me? Better? Okay.
I think it's a little bit closer.
Okay, thank you. Thanks. So I'm going to move this so I can see it. So what is precision medicine? Precision medicine is an approach to integrate individuals' medical, sociocultural history, genetics, multiple omics, environment, and lifestyle information to arrive at personal diagnoses, personal disease risk, personal therapies, and disease prevention. I think most of you know about endometriosis. It's a complex, hormone-dependent, systemic, progressive, inflammatory disease where endometrial-like tissue exists outside of the uterine cavity. And there are 3 kinds, main kinds. superficial, deep, and endometriomas. And in their ectopic sites, they elicit inflammation, fibrosis, pelvic and other pain, infertility, and marked decreased quality of life for patients. The etiologies are thought to be several. The main one is retrograde menstruation, where the menses go through the fallopian tubes and land in the pelvis, and this tissue is then gets onto the surface. But 90% of those who menstruate have retrograde menstruation, but 10% of those who menstruate have endometriosis. So there's something missing in the etiology. Some of it derives from stem cells from the basalis layer of the endometrium and also from the bone marrow. In addition, genetics and environment are thought to be key players. And it's important in taking a history to ask about family history. And very new data suggests that perhaps mucosal dysbiosis, so changes in the microbiome of the gut as well as the reproductive tract, may have an impact, as you'll see today. It affects about 50% of those who have a uterus who have infertility, so it's a major issue. And the take-home message for the pathophysiology is that there is enhanced estrogen signaling, dampened progesterone signaling, and immune dysfunction. Diagnosis, still, every time I give this talk year over year, I'm always changing the year. Now in 2025, it's still by surgery and histologic confirmation. But we're making advances in imaging. As I understand, the residents just had a session with Dr. Potter on imaging. And a 10-year delay from onset, somewhere between 4 to 11 years of delay of getting a diagnosis when the first symptoms present, is very demoralizing to patients. And also can affect progression of disease that can impact symptoms as well as fertility. The treatments, as you know, are mostly hormonal. And also there is variable benefit, as you'll see, and a high rate of recurrence of symptoms. And the hormones that are used for pain symptoms are totally contraindicated for fertility because most of them inhibit ovulation. And endometriosis, increasingly we are understanding, and you'll see more big data today to underscore this, that there are multiple comorbidities. It's not just one disease. Patients have fatigue, GI symptoms, autoimmune, inflammatory, metabolic, cardiovascular disorders, and cancers, and mainly ovarian and some evidence for endometrial. And the cost to the individual is very high. On a personal level and also on a financial level, as well as to the cost to the healthcare system. So what are we looking for out of precision medicine that may help us get our hands around this very unusual and hard to define disorder? So today, I'd like to begin with some advanced technologies and big data, giving now some candidates for non-invasive diagnostics, genetics and epidemiology and electronic health data, giving us information about comorbidities, systemic disease status, and also something novel called drug repurposing, and we'll get to that. And then data-driven approaches for drug discovery, and key is quality care and access to care for all. So big data reveal that there are now, by several industrious companies, that there are some non-invasive endometriosis biomarkers. The two and things that are sampled are blood, saliva, endometrium, and also now sort of the new kid on the block, the liquid biopsy of the endometrium, which is menstrual fluid and tissue. And so there are two tests. One is the endo test using microRNAs, 190 of them, very high sensitivity, very high specificity and accuracy according to the company. It still needs validation elsewhere, but it's only available in Europe and specifically in Switzerland and in France for 900 euros per test. It's a yes or no test. You have endo, you don't have endo. Doesn't say what kind. And so we need some additional diagnostics. The other is the Receptiva test by Cicero DX, a US-based company that is an endometrial biopsy for basically inflammation. And it's done in the window of implantation. So the goal initially was to look at the window in patients who have endo. It's now become more of a marker of inflammation in the uterus. And that also has high sensitivity and high specificity. So others are still in development, and the NIH has launched a whole program focused on endometriosis diagnostics, and we'll get to that later. So this, I think, is probably one of the most exciting things that precision medicine is now showing us, and that is there are shared processes in endometriosis and its comorbidities. Multimodal approaches, genomics, observational data, EHR phenotyping, and drugs support shared etiologic factors, target genes, signaling pathways, shared symptoms, and even some shared treatments between endo and its comorbidities. These highly support endometriosis as a multi-system disease and possible drug repositioning among the comorbidities. So here's an example. This first GWAS meta-analysis was done by the International Endometriosis Genome Consortium, and our team is part of that, and published recently 42 genome-wide loci for estrogen signaling, progesterone signaling, angiogenesis, metabolism, and pain. And importantly, correlations were found between endometriosis and 11 pain conditions, including migraine and inflammatory conditions. And multi-trait genetic analysis noted substantial sharing of variants of endometriosis with chronic pain and migraine diagnoses. And very recently, this is just within the last 3 months, a mouse model of endometriosis was developed where the investigators treated the mice who had the disease versus controls with a migraine medication, which is calcitonin gene-related peptide antagonist. And they found decrease in the lesions, decrease in the pain by the metrics they used. They did not look at fertility. So here's an opportunity. We're not quite at the point of prescribing this for patients, or maybe we are in multidisciplinary groups with good clinical trials, but possible for drug repurposing. Another, and this is sort of a classic paradigm for precision medicine. Here, you look at 2 diseases, gastrointestinal and endometriosis. Is there a relationship? And it's the integration of the observational data with the genetic data and the electronic health record data. So what they found in the UK Biobank, which is this gigantic biobank in the United Kingdom, they found a comorbid relationship of endo with GI disorders and especially with irritable bowel syndrome. So those who take care of patients with endo know that there's a high percentage of patients who also have GI disorders. In addition, they found genomic loci around the causal variants, so a genetic correlation. And interestingly, they looked at drug targets. 4 loci for endometriosis were the same as an IBS, and that was known prior for GI disorders, but it was new to endo. And they looked at some pain and immune modulators used for IBS that seem to work well, but with endometriosis trials, they're still in their infancy, so we still have some room to grow. In addition, EHR data showed that medication usage, 7 meds for treating gastroesophageal reflux, peptic ulcer, and IBS, were significantly increased in patients with endo, and increased use of hormone treatments in patients with these GI disorders, many of whom had endometriosis. So this is now beginning to pull together how different comorbidities have very similar, not all, but similar traits and also signaling pathways and therefore possibilities for repurposing drugs. Now, in our team, led by Marina Sirota and Tomiko Skotsky, and with their PhD student, Umair Khan. These are big data people. They are computational scientists who are part of our center, and they have used and mined UC-WEX and UCSF health big data looking for comorbidities. This is a very large data set, has inpatient and outpatient de-identified data with demographics, diagnostics, procedures, codes, top labs ordered, and meds. And what they did was they first looked at the medical records for diagnoses and identified endo patients, and then found and looked for associations. And there were two cohorts, the UCSF cohort of 5.5 million patients and UC-wide 8 million patients. Of these, so these are different, this is a different cohort. So the total is 13.5 million patients. That's a huge resource. They found that there were 42,300 endo patients. They also had a non-endo population of larger numbers. And then importantly, they also saw and were able to identify patients before diagnosis. So let's see what they found. The clinical associations they found were most of what you would expect. Cysts of the ovary, pain in the pelvis, abdominal pain, female genital organ symptoms, fibroids, and also female infertility. Now, in the pre-endometriosis cohort, they found some of the same diagnoses, which really says that the diagnoses, if you are looking and thinking about endo, you may start thinking about it even in, of course, an adolescent. So it also, I think, when you look at all these dots, these are all different diagnoses. It really points to a highly heterogeneous disease. Mm-hmm. Big data also reveal multi-organ dysfunction for fertility and pregnancy outcomes. And there's some controversy here. First of all, on the endometrial side, impaired decidualization of the stroma, the lining of the uterus. It has to be in good shape in order for a pregnancy to occur and for good pregnancy outcomes. But patients who have endometriosis, and we've also found patients who have PCOS, have impaired decidualization, reflected in what's called progesterone resistance. So even though the progesterone levels are normal, the tissue is not seeing progesterone as it should, with altered gene expression, epigenetic changes, vascular maturation, and altered immune cell populations. So if you think about implantation, there's a lot going on there, and it needs to be orchestrated really well, not only by the right players, but also temporally. With regard to the ovary, there is some controversy about whether there's decreased ovarian reserve among patients with endo. Most of the data would support that patients who have ovarian endometriomas have slightly decreased reserve, but once those endometriomas are removed, that's when the big hit on the ovarian reserve happens, with some regain of the reserve over time. Treatment for infertility, ovarian stimulation, intrauterine insemination are pretty good, and not everybody needs IVF, but some patients do need IVF. And what has been found is that there are fewer oocytes from ovarian stimulation for IVF, fewer viable embryos in later stage disease, but the live birth rates are very similar. to patients who have unexplained infertility or male factor infertility. So patients who have endometriosis, whether or not they have infertility, have can have pregnancy complications. There's an increased risk of miscarriage, an increased risk of placenta previa and preterm birth, and more recently, and this is controversial also, for preeclampsia and fetal growth restriction. I think things are controversial because the patient populations are so heterogeneous. When you see odds ratios of 1.4, but placenta previa is up at 3 to 4. So it does raise the issue, and there was a commentary in Fertility and Sterility a couple of years ago about, as obstetricians, should we be asking patients about a history of endometriosis? The thinking is that most patients will have a normal pregnancy, but the more recent data show that more advanced disease, especially deep infiltrating disease, is correlated more with some of these disorders. And the previa is thought to be due to the hypercontractility of the uterine muscle. So it pushes the embryo down a little bit and it implants in the place where normally it wouldn't. So there are lots of things to be thinking about. Biomarkers for early diagnosis and disease stage, prognosticators if disease really impacts outcomes. How can we tell if you're pregnant and you have endo if you're going to have miscarriage, for example? And then, of course, therapies to improve outcomes targeted more at the endometrial level. Now, I'd like to switch gears a little bit to pain, which is the main presentation. And this is a slide from Susie Asani, who has published a lot. She's at the University of Michigan. I hope someday we can have her for grand rounds. Here for pain, there are 3 main types of endometriosis pain. Nociceptive pain, which is from the peripheral whoops, sorry, no. I need to go backwards. Here we go. Nociceptive pain, which comes from the peripheral nociceptors, which are cells that are waiting for some stimulus. And they're activated by estrogen, by inflammation in the peritoneal fluid, damaged tissues. And look what they release. They release calcitonin gene-related peptide. So thinking again about the migraine therapy. And this peptide has a neuroimmune function. Then there's neuropathic pain, which is pain elicited by nerve damage. And then something that is perhaps the most difficult to manage is nociplastic pain. And that is where these pain signals that normally are going up to the brain and dampened in the other direction. In nociplastic pain, there's a marked acceleration of signal. So there's a huge input to the brain and the dampening signals are reduced. And what that results in is increased sensitivity to pain and sensory stimuli. And it has been shown that there are changes in brain structure and function. Functional MRI has shown this. And it's predictive of poor or no treatment response. So I'm sure many of you have seen patients who have what the final conclusion is nociplastic pain or central sensitization. And it's very, very challenging to manage. Now, there are some other new players that are beginning to be entertained about possible impacts on endometriosis. And this has to come from big data from the microbiomes, all the microbiota in the gut, for instance. Now, the gut is a regulator of the immune system, so it's not so difficult to sort of connect the dots with endometriosis. It also influences mood and pain perception. And there's a group of bacteria called the Astrabolome that in dysbiotic, so an abnormal ratio of all the different microflora, these bacteria unconjugate estrogen. So estrogen conjugates sit there and these bacteria release estrogen, estradiol, which can influence disease and it can also dysregulate some of the CNS signaling pathways relevant to central sensitization. So people began thinking about this when an investigator using a mouse model made endometriosis by putting fragments of the uterine horns into the pelvis. The animals got disease, and then they had controls. And they looked at the gut, and they found a marked difference in the microbiome of the gut of animals that had induced endometriosis. These had more disease than the ones who, metronidazole was given, and that decreased the disease burden. They did not at that time measure pain, but they had subsequently, and it improves it. So what about people? Endometriosis patients have markedly decreased gut microbial diversity. There's an increase in gram-negative bacteria and decreased protective microbes and short-chain fatty acids, especially in patients with stage 3-4. And there was a study done a few years ago, 37 patients with stage 3-4 given lactofem, which is a probiotic, for 8 weeks. And then visual analog scales for pain were recorded at 12 weeks versus placebo. And they found that the scores were markedly improved. Now, we are at a point where we really need good clinical studies. Most of the studies are single arm, no control, not randomized. So if anyone's interested in a career in endometriosis clinical research, this is a good one to think about. Now, also, the female reproductive tract microbiota has been implicated in endometriosis. Several years ago, an investigator found increase in E. coli numbers in menstrual blood and peritoneal fluid of patients, increased risk of endo from large epidemiologic studies have shown increase with a history of PID, chronic endometritis, and lower reproductive tract infection. And chronic endometritis gives the same phenotype in the lining of the uterus that we see in patients with endometriosis, that is progesterone resistance. Now, in patients with endo, the cervix and vagina and endometrium bacteria have been looked at in a few studies. And what was found was increased gram-negative bacteria, decreased lactobacillus dominance, which, as you know, is important, especially for vaginal health, and also for the endometrium, and 50% common flora with the gut microbiome. So there's a trend going on here. And just about a year ago, a group in Japan reported that in patients who had endometriosis versus controls who were undergoing surgery, they did an endometrial biopsy, and 64% of the patients with disease were colonized by Fusobacterium, which is not something we normally think about as an infectious disease, but that was compared to 7% of controls. This group then created a mouse model, and they infected the mice with Fusobacterium or not, and they found the infected mice had more lesions, bigger lesions, and when treated with chloramphenicol and or metronidazole, the lesion sizes and numbers decreased. So very promising. A human study was done where antibiotics and a GnRH analog were given preoperatively, and the endometrium was looked at, and there was decreased colonization and decreased features of inflammation, CD68, proliferation, Ki67, angiogenesis, CD31. They didn't look at any outcomes of pain. We have no info on fertility, but again, this is something that's very intriguing, but again, we need good studies and good data. And when we think about infertility, there are some big data approaches to look at the endometrium. We know that about 30% of infertile women have some kind of pathologic bacteria, and there are 2 commercial tests, and I have no benefit from any of these companies, The EMA test, which is the endometrial microbiome metagenomic analysis, and the ALICE test for chronic endometritis. And these have not yet been studied in select endometriosis populations. And there's one report of therapeutic interventions improving IVF pregnancy outcomes. So something to be thinking about. Sometimes patients don't have symptoms if they have chronic endometritis, or they may have colonization without symptoms, but still we need good data. Now, our team, again, led by Marina Sirota and Tomiko Oskatsky, have been working on drug discovery, and they have accessed information from the GEO database, which has millions of samples, and something else called the connectivity map. So what this is an collection of expression data from cultured human cells. And they basically test compounds to see how these compounds may reverse abnormal signaling in these human cells in culture. So they took data from our team, bulk gene expression data, and which showed differential expression signatures, unstratified, stratified, et cetera. And they applied their algorithm, and the reversal, basically it was drug repurposing candidates to reverse the endometrial disease gene transcriptome networks. And here is the reversal map. And the top hit was, not surprisingly, a non-steroidal anti-inflammatory. So it's really proof of concept in some way. But does this really matter? So we have a collaborator in Emory, Stacy McAllister, who has a rat pain model of endometriosis. And she tested phenoprofen versus ibuprofen. So this is the baseline. Then the animals get endometriosis and they have higher pain. And then you treat with phenoprofen, they go back to baseline, as they do with ibuprofen. So proof of principle. Now there are some other drug classes that we have found that have emerged as potential compounds of interest for pain and possibly infertility. And we were somewhat blown away to see that antibacterials topped the list as we're thinking of other paradigms about endometriosis. And you can see the whole list here. And I think it's important also to think about how these drugs, there could be single therapy, there could be multi-drug therapies for multi-drug targets. And by these kinds of analyses, you can actually come up with some single drug and multi-drug targets. So lots of data to mine. So looking at current and future endometriosis therapies, most of what we base our therapies on has to do with the fertility preference of the patient. So patients with pelvic pain going to conceive in the next 3 months, yes, then treatment for infertility or surgical management as needed. No, possibly surgical management, but also medical management. And so the classical approaches are the non-steroidals, sometimes analgesics, contraceptive steroids, progestins, selective progesterone receptor modulators, GnRH analogs, agonists, antagonists, aromatase inhibitors to dampen down the estrogen stimulus, dopamine agonists, which are anti-angiogenic, tissue-specific selective estrogen receptor modulators like beta-doxephene, antidepressants, and anti-anxiety meds. And the whole goal of medical management is to decrease inflammation, decrease ovarian estrogen production and synthesis of estrogen anywhere, even in the lesions, and counteract the effects of estrogen. But it doesn't say anything about possible bacteria or other things. Interestingly, and this summary may be a little misleading, it says 25 to 34% of patients have no reduction in their endometriosis pain with medical or surgical therapy. When you first take a group of patients, this is the result of a systematic review by Christian Becker at Oxford. And in the first 2 to 24 months, about 10 to 20% of patients had no response. And then over time, there was an increase to about 60% who still had pain at the end of this 24 or 2-month period, depending on the patient's duration. So this is unacceptable. Patients have pain, and we need to help to alleviate that. So I think there are opportunities for innovations, individual therapies, combination therapies, nutrients, diet. I refer my patients to the Harvard website for anti-inflammatory diets. I don't know if it really works, but patients seem to think that it helps. Probiotics, antibiotics maybe, and looking at comorbidities for mining and repurposing drugs, as we've seen, and reversal scores, as you have seen also. So there's clearly a need for a multidisciplinary approach to treat the patient with endometriosis, and totally in collaboration with the patient and what her goals are. So this is a multidisciplinary disease, gynecologic, urologic, GI, musculoskeletal, and also centrally. And there are classical approaches that for many work, but for many don't work. And that's where the opportunity is for innovation. So we have a center called the UCSF Stanford Endometriosis Center for Discovery, Innovation, Training, and Community Engagement. Myself and Dr. Sirota are from UCSF as the PIs, along with Dr. Giudice at Stanford. And the central theme is endometriosis precision medicine. And we are pursuing multidisciplinary, multiomics, and data-driven approaches in endometriosis pathobiology, disease stratification, comorbidity identification, really trying to make personalized care a reality, including risk of disease and sequelae and responses to therapy. If you look at most studies, there's always a percentage of patients of non-responders. So why is that? Is it genetic? Is it something else? Is it epigenetic? We don't yet know. And also, we have a major goal of raising awareness in our community and to facilitate access of quality care for all. This is our center. We have 3 projects: single-cell transcriptome and immunome, proteome, exposome, metabolome by Susan Fisher and Tracy Woodruff, and also Josh Robinson. This is my team's project, and along with Dr. Giudice, and Dr. Sirota and her team lead Project 3. We have lots of collaborators: the Earth Center, the Black Women's Health and Livelihood Initiative, and the Center for Reproductive Sciences, the California Department of Toxic Substance Control, and the efforts are led by Dr. Jun-Soo Park. We also have collaborators at Emory, Columbia, and Rutgers. Our surgical teams are amazing, and we have a uterine disorder biorepository. But we also have this education and community outreach core. And this is really the core of our reaching out to our community. In our PO1, just in this past March, which is Endometriosis Month, we showed the documentary called Below the Belt. And this core is led by Dr. Jessica Apoko-Anani, who's now at Rutgers, and also Dr. Ito. And we're so proud that our residents put together a video under Dr. Ito's guidance and Dr. Lager. It's a video in office about endometriosis. What is it? What to expect? So I really want to thank you with huge gratitude for being so engaged. The WHO has issued a fact sheet, and we were part of this, about endometriosis. So a global message from the WHO that this is a disease and it's impairing quality of life, and patients need to be listened to. And also, there are advocacy groups that have really enabled national action plans in Australia, the UK, France, and Denmark. Health policy and research funding decision makers. Periodically, we send out manuscripts to various journals to try to raise awareness, and advocacy groups. Endometriosis.org is set up by a patient. It is not what you generally find on the web, which can be filled with misinformation. This is all vetted. Marches like the Endo March in March, sponsored by the Najat Family Foundation, and webinars and grassroots engagement. So remember, March is Endo Month, so look at our website to see what's going on, if you would. Now, finally, with regard to funding, the NIH is now up at 30 million per year in US dollars in 2025. And just recently, they launched in August the ACT Endo Challenge, which is a certain amount of money put aside so that those in industry who are developing diagnostics, imaging, non-invasive molecular diagnostics, and the like, coupled with AI and machine learning. And this is now ongoing. So the winners haven't been identified yet, but it's pretty exciting. I hope we get some good results from this initiative. So there are so many people to acknowledge. I can't individually acknowledge them, but these are so many people who have interfaced with our team, many of whom are part of our center. And of course, there is special gratitude to all the patients who have participated in endometriosis research and our funders, mainly the NIH. So thank you so much for your attention.